Hello and welcome everybody to the UCL lunch hour lecture on social prescribing, groundbreaking or gimmicky. My name is Agiris Stringaris. I'm a professor of child and adolescent psychiatry here at UCL, co-director of the Anxiety, Self-Image and Mood Lab and clinic at the UCL. And I'm also one of the UCL Pro Vice Provosts co-leading with Professor Essie Bidding, the grand challenges for mental health and well-being. It is a great pleasure, as it is an honor, to be welcoming today Professor Daisy Fancourt. Professor Fancourt is a professor of psychobiology and epidemiology here at UCL and head of the social biobehavioural research group. She has really done groundbreaking research on the topic you're going to be listening today, amongst many other things. Broadly speaking, she focuses on social behaviors on health and their effects on health, including things like loneliness, social isolation, and leisure activities. She is the director of the World Health Organization Collaborating Center on Arts and Health, and a technical advisor to the WHO and a scientific advisor to the UK government. I have had the pleasure of interacting with her in these roles, and I must say that her input is always extremely illuminating. Needless to say that she has written loads of papers and is listed as one of the most cited scientists in her field in the world. So this is really fantastic that we have you here, Daisy. Before we begin, I wanted to let you know that we'll have some time at the end of the lecture for questions. We'll have about 15 minutes. And you can submit these at any point using Slido. If you enter into your internet browser and entering the code of the event, then someone will hand those questions over to us. I can see the questions as well, and as I said, just use Slido, sli.do. And yeah, I look forward to your talk, Daisy. Thank you very much for coming today.
Thank you so much, Agiris, and it is such a pleasure to be presenting to you today. As you heard, I'm going to be presenting on the topic of social prescribing, which is one that I've been interested in over the last few years. For those of you who aren't familiar with my research group, we are the Social Biobehavioural Research Group at UCL, and we focus both on social deficits like loneliness and isolation, and also social assets like engagement with community activities, arts, leisure, and other kinds of groups within communities. And really, we're interested in asking, how do these social behaviours and our social connections affect our health outcomes? What are the mechanisms that underlie this? Who benefits most? And how can we actually affect change so that people engage in these beneficial behaviours more? And over the last few years, we've been conducting research in different strands of work, including clinical trials, epidemiological research, psychobiological research, behavioural science, and also developing new theory following frameworks of complexity science. So I'll talk to you about various evidence that we've contributed to over the last few years in these different strands. But social prescribing is a topic that's really captured our attention increasingly over the last few years. It's one that some of you may have heard of already. If you haven't, then this is the extremely snappy definition of it. It's a means for trusted individuals in clinical or community settings to identify people who have non-medical health-related social needs and to connect them to non-clinical supports and services within the community. And this is done by producing what's called a social prescription, which is a little bit like a drugs-based prescription, but it's a non-medical version. And it's aimed to improve health and well-being and support broader health-related factors like social connections. This definition was only published last year, but social prescribing is actually a topic that's got a much longer history. The UK was one of the major leaders and pioneers in this field. Back in the 1990s, we started to have exercise on referral. So GPs could refer people through to exercise programs. And this was followed quite quickly by arts on prescription as well. Some of the organisations that really led this work include the Bromley by Bow Centre in East London, which opened what was called a Healthy Living Centre in 1997 that was really focused on helping to connect people to these kinds of community resources. And one of the other early examples was one called Artlift, which was started by a GP called Simon Ofer in Dursley, which engaged an artist in residence within a GP practice to start referring people through to arts classes. But it's really been since 2019 that this has been a proper national programme in the UK, and we're the first country that actually has a national programme like this. Initially, when the government announced it, they proposed 1,000 link workers. And link workers are the people who you would see if you're given a social prescription. So if someone like a GP says that they think you could benefit from community-based support, they would pass you on to a link worker who can have much longer consultations with you, who can help you to identify appropriate activities you can engage in, who can think holistically what your goals are, what matters to you. Practically and logistically, can you get public transport to classes? Can you afford classes? This kind of thing. Initially, when these link workers were announced, there was an ambition to have 900,000 people a year referred by 2022, 2024. But actually, we found nearly 2 years ago that there had been around 3 million people who actually had received social prescribing in that time. So there's been a new commitment to increase the number of link workers, with a particular focus on people who have long-term conditions, mental health problems, loneliness, or complex social needs. And in fact, alongside these developments in the UK, there's been a massive proliferation of social prescribing, with now over 40 countries around the world having pilots or programs of some sort. So it really seems a kind of growth area within health services. I think the problem is that the rollout of the scheme has often happened ahead of actually having the formal evidence base, which means that when there have then been systematic reviews about social prescribing, they've generally highlighted a majority of small-scale and relatively low-quality studies with high risks of bias. And this has led to some pretty damning verdicts about it, to be honest. My favourite being, even good enough is severely lacking from the social prescribing literature. So this has naturally wobbled people a bit, thinking, well, is this just a gimmick? Is this just something that sounds innovative? Is it a fad? Or does it actually have a place within healthcare services, and can it actually address health needs? So my view that I want to put forward today is there's actually a major flaw in how we're thinking about social prescribing. And this underlines why we're seeing these disappointing conclusions from reviews. So social prescribing is actually far more complex than we normally acknowledge. This is a horrifically small figure that I've put up here, and I'm not intending you to be able to read all of this on the left. But the point here is that the pathway that people go through within social prescribing is hugely complex. They can be referred by different people. They often get connected to this link worker or care navigator. They can then meet this person once, twice, 6 times, 8 times. There's huge variety in that. They can be connected to any number of different activities lasting any length of time. And there can be any range of goals or outcomes that people are hoping as a result of this. Even the activities that people can be referred to are extraordinarily diverse, ranging from things like being given benefits advice to getting employment support, or going to weeks after weeks of community-based social groups or clubs. So as a result of this, I think that asking, does social prescribing work? It's a bit like asking, do drugs work? We'd be saying, well, which drugs? For whom? What problem are you trying to solve? What outcome do you have in mind? I mean, if we take paracetamol, for example, that might work wonders for your headache. But if you're taking it to try and reduce hypertension, it would be useless. I mean, regular paracetamol actually increases blood pressure. So I think we have to think about social prescribing in this same way. Essentially, I think we need to throw out the old way of thinking about social prescribing as this single intervention and basically start again. So what I want to do today is to break this down into 3 different areas, one of which is asking, does engagement in the activities that occur as a result of social prescriptions actually have health benefits? Is there actually an evidence base that community groups, leisure activities are beneficial for health? I think working backwards, the second question is then, can social prescribing effectively connect people to these activities, particularly the people who might not normally engage of their own volition in these activities? And then I think the third question is whether the whole mechanism of referral through to activity, through to health benefits, actually works for specific populations with specific health outcomes in mind. So this is how I'd like to structure my talk with you today, is by starting off by thinking about engagement in the activities and then working backwards to connection and referral. In the interest of time, I'm going to speak largely about social prescribing activities that relate to leisure, community groups, exercise. So I won't mention so much about things like referrals to benefits advice or job support, because I feel like there's a slightly separate literature on some of those things. And also I feel like these community groups are some of the things that perhaps are met with more skepticism because it is a much newer literature that can talk about their benefits. So to start with a little bit of theory, let's think, how is it that referral to some kind of leisure or community group through social prescribing would actually lead to health outcomes? Within my team over the last few years, we've been really trying to develop the theory around this, and we've been breaking it down into steps relating to what are the active ingredients in these activities that people get referred to in social prescribing, what are the mechanisms that these ingredients activate, and then what are the health outcomes that can occur as a result. So if we break each of these three steps down into more detail, when we think about ingredients, one of the frameworks that we've published is called INNATE, and it's about identifying the intrinsic ingredients within leisure activities that could be beneficial to health. So we're not trying to map every single ingredient, but we're sort of saying, what are the components in activities that could lead to those health benefits? And broadly, we can think about some of these as relating to the project or activity. So what is it that people are attending? What's the dose? How often do they go? What's the content of whatever they're receiving? What are the various sensory, cognitive, physical stimuli they get as a result? Another set of ingredients relate to the people. Are people doing this on their own in their own homes, or are these activities bringing them into contact with other people? Are there leaders or guides or facilitators who are also present in these activities? And also, what's the context? What's the environment or atmosphere? Engaging, spending time in nature versus going to a library versus being in your own home are very different experiences that bring different things that can affect our health. So if we're thinking about what these ingredients are, it gives us a way of starting to articulate what it is in the leisure activities that could be beneficial. And naturally, there are some activities within leisure that have got core ingredients we know are beneficial to health, like providing physical activity so people aren't sedentary, providing social interaction or cognitive stimulation, or giving them a chance to exercise imagination or creativity or autonomy. Using frameworks like this, we've actually been able to start comparing activities. I've given an example of some of these visual maps we've been able to create. So we can start saying, well, a physical activity referral is different to a community arts group in these ingredients, but it's actually shared in these other ingredients. And this allows us to have a slightly more robust framework for how we're talking about these, and allows us as well to design trials where we can be very careful about which ingredients we're trying to compare in experimental or control groups. Once we've thought about these ingredients, the next question is how these actually lead to health outcomes. And we published a theoretical review paper in the Lancet Psychiatry a few years ago, where we looked at leisure activities and said, how do they actually influence our mental and physical health? And we identified actually hundreds of papers that had looked at different mechanisms that can be activated. So things like psychological processes, for example, leisure activities helping to reduce psychological stress, improve people's sense of self-esteem, self-identity, helping with emotion regulation, for example. Biological processes like reductions in stress hormones, changes in profiles of inflammation within the immune system, alterations in cardiovascular and metabolic processes, all of which affect health outcomes. Social processes like reducing loneliness, enhancing social bonding, for example, and behavioural processes. One of the common findings is that people who engage more in one kind of leisure activity, whatever in their lives, are actually more likely to engage in other health promoting behaviours, an effect called the spillover effect. So actually you find that people who start doing one community-based activity start to accumulate more and more, or make other changes related to things like employment, for example, or housing. So they can have these trickle-down effects as well. I mean, naturally, these processes are complex because we're talking about highly complex human behaviours. But through the lens of complexity science, which I mentioned at the start, we've actually got a way that we can research this. And in research papers, there's now an increasing ability to map what these ingredients are and demonstrate what these mechanisms are, and demonstrate how the different ingredients in leisure activities lead to certain mechanisms being activated and how these synergistically affect mental and physical health outcomes. I'm not going to talk too much about the mechanistic side of it today, because what I really want to focus on is the outcomes side to this. And even if I just pick one population, let's say older adults, there's an incredibly diverse literature now demonstrating the myriad health benefits that we get from engaging in leisure or community-based activities. So, for example, hundreds of studies looking at the various activities that are commonly prescribed in social prescribing show that they can reduce depression. For example, meta-analyses of volunteering schemes show that they lead to reductions in depressive symptoms. We see similar things for nature-based interventions like gardening or horticultural therapy. We see it as well for music-based activities, so community group music activities, and also things like befriending schemes. So this is starting to give us, I'm trying to illustrate the fact that there is a very strong evidence base, both from clinical trials and epidemiological work, showing that these kinds of activities can have benefits for mental health. And importantly, we see them not only supporting with the management of symptoms for people who already have a mental illness, but also helping to reduce the risk of people developing mental illness if they've got other risk factors, for example, they're lonely or something in the first place. If we stick with older adults as our example and think about cognition as well, we've got similar benefits coming through from lots and lots of studies about leisure and community-based activities. Meta-analyses that have pooled the results from over 2 million people show that those who engage regularly in leisure activities have a reduced risk of developing dementia. And this is even when we take account of factors like education, other aspects of lifestyle, income, demographics that might explain why we would see this association. Instead, what we think is that these kinds of activities increase cognitive reserve, which is a term used to describe the resilience of the brain against cognitive decline and dementia. And again, we see this coming through in meta-analyses and studies across very diverse kinds of leisure activities. For example, older adults who engage regularly in music making over time have better preservation of attention and working memory as they age. Analyses that we've carried out looking at cultural engagement, so going to things like the cinema, museums, concerts, galleries. These all show that people who are regularly engaged with social activities or all these kinds of cultural activities have a longer time to the onset of dementia and better maintenance of cognitive function. And similarly, studies that have looked at gardening and outdoors activities as well have shown the same kind of thing, so better preservation of cognition over time. From a physical health perspective as well, it's the same kind of picture coming through about lots of diverse health benefits from engagement in leisure and community activities. So, for example, for people who've got hypertension, listening to music on a daily basis as a stress reducing strategy actually leads to reductions in blood pressure of 9 points over and above the reductions that are seen in regular treatments like lifestyle changes or medications. So these trials have directly compared those existing treatments like lifestyle and medication with the same things, adding music on top, and seen these additional improvements from that literature. Similar studies have also looked at dance in relation to things like body fat mass. Now, of course, you could argue that dance is a form of exercise, so naturally you might expect to see improvements in things like BMI, body fat mass, etc. But again, lots of these trials have actually compared dance to other exercise initiatives and found that dance has got better outcomes. And one of the predicted reasons around this is that dance has those added ingredients of creativity, imagination, providing outlets for emotion regulation. So it's bringing in a psychological component as well as the physical component that we get through exercise, which means that there are additional mechanisms it can activate to help people feel better about themselves, to maintain healthy behaviours, and ultimately to have better health outcomes. I mentioned as well like the ingredients of the environment you're engaging in, and actually studies that look at things like engagement in areas of high green space or low green space show similar health benefits. This was a meta-analysis of studies that had looked at how outdoors engagement relates to type 2 diabetes and found that the volume of green space in the outdoors led to better outcomes compared to people who were outdoors in areas that had less green space. So probably not surprising, there have now been quite a few meta-analyses and also just general epidemiological studies that have looked at how leisure engagement and community activities relate to sort of very long-term things like mortality risk. And again, what comes through a lot from these studies is the suggestion that if people are engaged more in these activities, they could actually more likely to have a longer lifespan. Now, naturally, we have to ask questions about causality here, and these studies, unlike the other ones that I presented to you, can only be done through observational research without being able to have clinical trials to really get at that causality issue. But even taking account of diverse confounding factors, we do see repeatedly suggestions that engagement with these activities is linked in with longer lifespan or increased survival risk, as it's presented in some studies. And again, from diverse different activities. One of the things that I've always slightly worried about in this literature was lots of these studies have been conducted in Western global North high income settings. So I did sometimes wonder if these effects were actually also found in other cultural contexts where there might be different associations with leisure, or there might be different amounts of leisure time available to people, or different cultural or social norms around leisure activities. So recently, my team and I have started doing a lot more global epidemiological work. This is an example paper that we published a couple of years ago in Nature Medicine, where we actually ran analyses between, this time, hobby engagements and diverse health outcomes 8 years later. We ran multiple different statistical approaches in 16 different countries. And then we meta-analysed our own findings to each of the different statistical methods. And we actually still found that even from different cultural settings, when we looked at the aggregate effects, having hobbies was associated with lower depressive symptoms, better self-reported health, higher happiness, and higher life satisfaction 8 years later. So we now believe that these things aren't just the phenomena of particular cultural contexts. The evidence that I'm presenting here is a very small snapshot of how much is out there. So I'm really barely scratching the surface. Just to give an example on the arts side, I've been working with the World Health Organization on the relationship between arts and health for the last 8 years. We published an evidence synthesis report back in 2019, which summarized the findings from 3,500 studies and demonstrated extremely diverse aspects of health that are affected by engagement in the arts, both in terms of the management and treatment of diverse mental and physical health conditions, but also in broader aspects of health that help to prevent illness or play a part in broader health promotion. So overall, I would say that when we're thinking about the engagement in activities, I'd argue that there is a good evidence that leisure community groups have diverse health benefits for people who've got multiple different mental and physical health conditions, and also people who might be externally healthy but might still be at risk of developing problems at other points in their lives. So this then really brings us to the next question is social prescribing therefore a good way to connect people to these kinds of activities? And this is a really important question to ask, because when we think about leisure and community activities, we have to acknowledge that there is huge heterogeneity in terms of who actually engages in these activities day to day, week by week. If we take arts as an example, my colleagues and I have been working on some analyses just looking at one very specific behaviour of engaging with community arts and music groups or clubs. We've been analysing data from the World Value Survey, which involves 100,000 people across 60 countries, looking at, well, how prevalent is it that people actually engage in arts and music groups? As you can see from this map, there is huge variety in the percentage of people who say that they do this week by week and month by month. And when we actually then look at what the predictors of who these people are, we see that people are much more likely to engage if they've got high levels of education, if they have got higher wealth, and various other demographic factors as well, including their gender. People who are male generally are more likely to engage in these kinds of activities. These are the analyses that we ran aggregating all countries together, but actually when we split it up by geographical region across the world, we were actually quite surprised at exactly the same pattern that we find in all parts of the world. So this highlights that there is an implicit bias in terms of who can and does access these different activities. And this is really important because the gradient that we see here is the same gradient that we see in people's health. In other words, the people who are most likely to develop health problems are the ones who are the least likely to engage in arts, leisure, community groups. So this is something that we really have to consider addressing, because if we're thinking that these activities are beneficial to health, then having such inequalities in access, could arguably be exacerbating health inequalities. Again, from a theory perspective, my team and I have been trying to understand what the barriers to people's engagement might be. So again, if we stick with the example of arts, we recently published a new framework where we mapped what the different barriers could be. Often what we see from a policy perspective is people talk about what we call the micro-level factors, so the factors that affect an individual. So it might be things like people's own experience or training in the arts, their so-called capabilities. Might be barriers to engagement. If you've never had any kind of arts or music training, are you less likely, therefore, but you are less likely to go and join a music group within your community, because you might just feel like you don't have the skills and capabilities to do this. But we've been really keen to emphasize that these individual factors are only a very small part of the picture. There are actually many external factors that can exert much greater influence. So things like what opportunities are actually available in your community. If you live in a deprived area where there are no community arts venues, there are no libraries, for example, there are no available or affordable groups for you to do, then of course you're not going to be very likely to engage. And there can also be much broader factors like the amount of public funding that might be available to artists to run programs within communities. The social norms for different population groups. Is it something that your particular demographic, your particular cultural group or social group normally does, and therefore that you feel is valuable for you to do? And there can even be very broad infrastructural factors like what public transport is available to you. So this model is quite helpful for us in thinking about how we might want to try and improve access. And it's also really helpful for thinking about how social prescribing works. Because in theory, social prescribing is a really clever model for addressing inequalities engagement, because it tackles multiple different barriers simultaneously. It actually embeds referrals to these programs within healthcare, providing them new means of accessing people. It provides public funding. It actually addresses norms and provides establishment of new norms and high-profile examples of why people should engage, and even sort of public health awareness campaigns around this as well. And it can also provide new opportunities for people to engage, and it engages arts and cultural organisations too in delivery of services within healthcare. The question is, does it actually work in practice? This is a claim that's actually proved quite controversial. And over the years, there have been concerns that social prescribing actually can't address upstream determinants of inequalities, and even might be provided disproportionately more to people who are less disadvantaged. Now, I'm not personally claiming that social prescribing can address upstream determinants of health inequalities, like eradicating poverty, for example. But actually, I'm going to argue that it does broaden existing health service provision and increase uptake of community activities, particularly amongst those who are the least likely to engage. And this is something that I'm arguing based on the analyses that my colleagues and I at UCL have been undertaking over the last few years, comparing lots of different kinds of data. So some of our early work on this looked at GP records, and we were looking at the records in Northwest London, which has got a really nice integrated care system, and saying, well, which people were referred to social prescribing just when the scheme was starting in Northwest London. And what we actually found was that the people living in more deprived areas who were more likely to be referred. It was also people with more long-term conditions. It was people who were making more use of primary healthcare like GPs in the first place. And it was actually quite a diverse mix of people based on ethnicity. So this actually was really promising. It suggested that social prescribing was indeed going to the people who arguably could benefit from this the most. But naturally, there are still some limitations here. This was only looking at GP referrals, and social prescribing can actually be a lot broader than this. You haven't got to be referred by a GP. You could be referred by a social worker, by a voluntary organisation, by your school, for example, and you could even self-refer. So one of the ways that we've got around this is we've recently integrated questions on social prescribing into one of the national cohorts, the English Longitudinal Study of Ageing. So we had a number of different aspects of social prescribing activities, and we asked people if a doctor or social worker or other professional had referred them to any of these in the last 2 years. interestingly, what we found really corroborated our findings from the North West London data. So social prescribing was offered more to individuals experiencing greater socioeconomic adversity. So for example, people receiving benefits or in the lowest wealth tertile. There was also no evidence that people who were more educated were more likely to access it too. So that was really promising. We also found that referrals were more common amongst people who already had depression, who were physically inactive, who had chronic pain, or who had multiple long-term conditions. As always, we always like to try and find flaws with our research, so that the limitation in this sense was that this was based on people having to recall had they been referred. And of course, some people might have forgotten if they were referred and they said no. So the third kind of evidence that we've been working with is from a database called Elemental. Now, this is the largest cloud-based platform for tracking social prescribing activities in the UK. It serves a population of 20 million people. And it's a way where all the services, so GPs, voluntary organisations, etc., can input their data. So it's really effective for tracking individuals as they get referred, as they meet the link worker, as they go to their activities. Again, what we found here, though, is completely corroborating what we've got from the other two kinds of evidence. Social prescribing is actually reaching those who need it most. For example, people who lived in more deprived areas, people from ethnic minority groups. And one of the things that we're finding as well is that there are these different pathways. There are the medical pathway through GPs, or the other kinds of pathways that I mentioned through things like social workers or voluntary organisations. Around 3/4 of referrals are via the medical routes, but actually we find that it's the non-medical route that's sometimes most effective at reaching people in minority groups or those who might not be likely to engage with these activities normally. But we found a couple of things that are interesting in this as well. That mental health is the lead reason that people are referred to social prescribing. But there is a kind of challenge that, despite 90% of referrals actually leading to someone meeting with a link worker and planning what activities they're going to do, only 38% actually ends up doing any kinds of activities. So this highlights a kind of challenge, a shortfall perhaps in community activities or resources, or a suggestion that social prescribing might sometimes be used a bit like an initial counselling model rather than actually helping to get people through to activities. And we've also found a lot of variability in different regions and different countries within the UK. So it shows that there's a lot from a practice perspective that can be developed to optimise this. We're also currently running more analyses using a database called CPRD, which is a big clinical database. So that's looking at even larger numbers, and we're going to have the results from that out soon. But what's also quite exciting is when we look outside the UK, so even countries where social prescribing has yet to roll out on a national level, we're actually again seeing some similar predictions that people from all backgrounds are just as likely to say that they would follow a referral and take up an activity if they were prescribed. These are some analyses that I've just finished where I've been looking at data from the US. It was a representative sample of adults who were asked, would they actually engage in arts activities if they were referred by a medical professional? And we found that there was no difference in response based on people's demographics. And in fact, overall, 3/4 of people said they thought they would take up a prescription if they were offered. And that's meaningful, given only half of adults in the US currently say they do any arts activities in a year. So actually suggestions it could increase behaviours generally, and promisingly, no signs that this would be skewed according to people's background. So overall, I would say, yes, I do think that there is now evidence that social prescribing is an effective way to get people who could benefit the most and who don't currently engage linked in to community activities and leisure activities that could benefit them. So this then brings me to my third question of, is there actually any evidence then that the whole referral pathway from patient identification to referral to a link worker to activity engagement actually works? Like I said, I think we need to avoid the perils of looking at this too broadly and asking, does social prescribing work, just like do drugs work? But I think, so we don't want to have some mammoth RCT that throws all patient groups and all activities together. But if we actually design more targeted clinical trials focused on particular patient populations or demographic groups, we actually get some really interesting results. So I wanted to share some of these trials with you that have happened over the last few years. One of the leading trials on this was actually published 25 years ago, so very much at the point that social prescribing was happening in some places, but not a formal programme. It was a multi-site randomized control trial of 26 GP practices in Avon, and it was for people that the GPs considered had psychosocial problems that could benefit from voluntary sector support. So the GPs and link workers met with them, helped them find appropriate groups, and then kept meeting to sort of encourage attendance. And people were referred to things like Alcoholics Anonymous meetings, Relate meetings, local carer support groups, toddler groups, etc. And compared with routine care, not receiving these referrals, people who engaged had reductions in anxiety, and they also felt more positive about their health, about life in general, and in their ability to carry out everyday activities. As another example, there have also been lots of trials that have now been meta-analysed looking at physical activity referrals for people as a strategy to try and reduce the development of chronic diseases. So these trials have looked at people being referred by health professionals to things like exercise initiatives, activities like Tai Chi. Generally, people have engaged for sort of 2.5 to 4 months as the length of intervention. And actually what all of these trials have shown is that people do change their levels of physical activity, and that this actually appears to be sustained even after the completion of their engagement in the program. So it suggests that these referrals can achieve behavioural change. Interestingly, is that these trials looked at people who were considered healthy in the first instance. So actually, when these meta-analyses look at various clinical outcomes like BMI, blood pressure, and cholesterol, they actually haven't found anything different. And I think this just really highlights the importance of considering what outcomes are likely in a particular group. If people are already very healthy, I'm not really sure why we'd be expecting changes in outcomes that are already within normal range. In fact, studies that have focused particularly on people who are actually outside normal range, like one of the trials looked at people who already had hypertension and put them into Tai Chi activities for 6 months. These ones actually did find reductions in blood pressure and BMI. But this really just reinforces that point I've kept making, that we have to be considering the population and the outcomes that are relevant to that population. Another trial, which has been led by our Argyris and colleagues in Greece, has been looking at arts-based prescribing for people with severe mental illness. So people have been randomized to receiving referrals to things like going to museums, to theatres, to concerts, to other cultural activities, versus being on waitlist control groups. And as you can see from these graphs, the groups that have received the arts and cultural referrals have had marked improvements in their depression and anxiety scores over the course of 12 weeks. And we're currently eagerly anticipating the results from when they've crossed over. So when the waitlist group have then also got their intervention, to see if this is replicated in them as well. And within the UK, we've looked at specific kinds of mental illness as well, like women who have postnatal depression. Over the last 10 years, I've worked with colleagues with designing community-based singing programs. So this time actually trying to design a bespoke activity that we feel is particularly relevant to that population. And this has been 10-week programs for mothers with postnatal depression to attend with their babies in order to see does this lead to reductions in their symptoms? And we've compared these singing groups, crucially, not just to usual care, but also to usual care plus play groups, the kinds of toddler groups that are already available in communities. So they would share quite a lot of the same active ingredients, like I mentioned at the start, but actually without the same arts and music-based components. And we've actually found that the singing group recovers around a month earlier than the other two groups, even though that singing and play group have got a lot of shared ingredients. And we followed this up with subsequent trials that have demonstrated the same results, even when the intervention is online. And we've also more recently completed a trial showing that over time, these results are maintained better in the bespoke singing groups compared to people who get referred to more traditional mum and baby toddler groups. So better maintenance of those results over time, and also highlighting sort of cost impact of that. And we've worked with the World Health Organization now on the rollout of this intervention on prescription in various countries around Europe, including Denmark and Romania. So naturally, an important question to this is, if we're seeing these benefits from clinical trials, what's the health economic impact? Now, it's very early to make big statements on the sort of financial impact of social prescribing as a whole, But if we take the same approach that we have through this presentation of thinking first about the activities and then about the whole referral mechanism, there are various ways that social prescribing could lead to cost savings. The first ones of these are through improvements of well-being. The Treasury holds sort of financial calculations about what our improvements in well-being are worth from a monetary perspective. And also it could be that if people are feeling better, they're more productive. So we can also look at the differences in productivity, people who might be able to work more or engage more in informal caring or labour around the home. So we've been working with DCMS over the last year, calculating what the health economic impact of arts activities within communities is. We've looked, for example, at general diverse arts activities for leisure within communities and shown that for adults, so working age adults in the UK, this combined well-being and productivity outcomes is worth over £18 billion in societal-wide health economic benefits every year, which when we consider that the arts and cultural budget is about 1 billion is an enormous return on investment just for the health-related outcomes, let alone anything else. Another way that things could save money is by reducing health service utilisation costs and actually using epidemiological approaches, so looking at long-term data that track people repeatedly over decades. We have found that when people increase their engagement in arts activities, they actually subsequently decrease their usage of more expensive things like secondary care, like inpatient care, nursing home visits, for example, and they actually make more use of primary care, so things like going to their doctors and their dentists, so actually things that might prevent them having to use the more expensive care later on. And within trials that look at the whole mechanism of social prescribing, we see the same pattern borne out. So in our Melodies for Mums programme, the Singing for Postnatal Depression, we found that the intervention group, just like we'd seen in the big data, they did initially increase their GP visits, but actually over time, they needed less and less expensive health services. So in fact, their health service usage got cheaper over time compared to people in the control group. And we've also conducted broader cost utility analyses. So for that singing intervention, we found that there was an 82 to 93% probability that it was cost effective, according to the NICE criteria on which we judge interventions in the UK. And it actually compared very favourably in terms of its cost and its cost effectiveness to other kinds of interventions that are available to mothers with postnatal depression. And broader data from the UK also suggests that providing arts on prescription leads to major reductions in health service demands. So for example, reductions in physician appointments of around 42% and emergency department visits of around 23%. And for social prescribing, these results are even greater amongst people who make very high use of health services in the first place. Again, I'm cautious about putting like one particular figure on what the economic return on investment is, because again, we're coming back to these very broad questions like, do drugs work? But there's been a really interesting recent report that looked at what the cost savings were being calculated as in specific areas or specific GP practices where they've done some more intensive monitoring. And essentially for every pound spent, the estimates that come back from all these different case studies range from around £2.14 to £8.56. So I'd say that there is promising evidence here and certainly things for us to take further in future research. In terms of next steps, I think we do need a lot more of these nuanced, high-quality clinical trials that will look at particular patient groups. So within my team at UCL, for example, we're currently leading a multi-site trial looking at child and adolescent mental health services, where we are offering social prescribing to young people who are on very long waiting lists for mental health care. We're actually into the final stages of this trial. We'll have the results this summer, but we're already producing quite a lot of guides about how these social prescribing pathways have been set up within these mental health settings. We're also leading multi-site trials in schools in a trial called ENACT, so working with 30 schools around England, looking at young people who are lonely and looking at whether social prescribing, if they're randomized to that, can reduce loneliness and improve mental health for those children who are late stages of primary school or early stages of secondary school. For all of these trials, we're adopting what's called hybrid designs, where we're equally interested in the clinical outcomes, but also the implementation. So we can say, how can we design these social prescribing pathways to be as effective as possible for these different populations? And we're also really delighted to have won the leadership of the Social Prescribing Youth Network, which is an international body trying to support the development of social prescribing in young people, which has typically been an area that's had much less research to date. We're also engaging in this on an international level, working with lots of different countries at the moment. One of these is the US, where we've recently completed an evaluation of 23 sites that have been piloting social prescribing. And we've got a new policy piece that hopefully will be out shortly as well, talking about what the potential of social prescribing, not just in countries like the UK that have national health services, but also countries that have got insurance-based healthcare systems. And with our work with WHO, we were really happy that actually the report that we wrote for them got a huge amount of traction, much more actually than was anticipated for a topic that probably wasn't initially seen as that central to health. But actually, as a result of this, we've seen a lot more arts and health policies developing in new countries. And we've been working very closely with WHO, including on the launch of a new arts health lab, which was started a couple of years ago, which is trying to affect policy change at international levels around arts and community arts practices to support health outcomes. And this, of course, includes social prescribing. And with WHO, we've got new technical reports underway and plans for new technical briefings and technical resolutions that would identify and sort of accept arts and community and leisure activities as a health behaviour, just like we have physical activity and diet, but recognising that these things also have health benefits and should be considered as things that we promote for people to support good health and well-being. So overall, I hope I've been able to give you a more comprehensive understanding of social prescribing and the potential that I believe it holds. Based on the evidence today, I'd say it seems certain that activities that people refer to are beneficial to health, and that there is very strong evidence that social prescribing can reach diverse populations, including those who are most in need. And I'd say that there's emerging promising evidence that the entire mechanism can be clinically effective and potentially cost effective too. I'm not by any claim or stretch of the imagination claiming that social prescribing is perfect. And there are lots of challenges, from lack of sufficient funding to voluntary organisations that deliver these activities, to insufficient training for community providers and link workers. We also lack a comprehensive data monitoring and national evaluation strategy. And there is much more limited work on social prescribing outside of GPs. But my goal today has really been to present the scientific evidence to you. So I'm not delved too much into these debates, but I would point you to some fantastic organisations like the National Academy for Social Prescribing and the Culture, Health and Wellbeing Alliance that are leading on these issues. But I'd say that social prescribing remains a model of care that is uniquely focused on the holistic needs of patients. And it takes a really essential preventative and community-based approach to thinking about health and illness. It's also really personalised, prioritising what actually matters to patients, which I think is absolutely critical. So overall, in the groundbreaking or gimmicky debate, I would say groundbreaking. Thank you very much.
Thank you very much, Professor Fancolt. This was great. I'm sure the audience will agree with me that it seems like there isn't just one Daisy Fancolt, but there are several. The amount of work can't have been done by one person. It's actually remarkable. It was a tour de force.
Well, it has not been. I would like to credit my fantastic team and the funders that have supported all of this work over the years.
Still, it is absolutely remarkable. Thank you so much. Also gives me very good arguments why I need to continue funding my expensive guitar hobby, guitar acquisition hobby myself. We have some very good questions that if you'd like me to, Daisy, I can read them out to you if that's okay.
Lovely.
The first one is, in your research, how has the reception from the medical community in primary and secondary care, for example, GPs and doctors, been towards social prescribing?
I've actually found it's been really favourable, because we all have the same aims here in trying to provide comprehensive care to patients. And actually social prescribing addresses lots of the areas that haven't been something that can be routinely offered by GPs before. We've worked a lot with GPs, for example, who've said if patients have got chronic diseases, they've got medical treatments there, but they don't have the things in place to support their broader mental health, to help them stop being lonely, or to help reduce stigma around the conditions they're now dealing with. And within our work specifically in mental health services, given the waiting lists are so long, the staff are fully aware that this is not ideal for patients. In child and adolescent mental health services, 3/4 of young people deteriorate on these waiting lists. So being able to offer things like social prescribing in that interim time is sort of a win-win for all of the stakeholders who are involved.
Yeah, great, thank you. Tara Levers from the Prudence Trust is asked the next question. What level of patient resistance to non-medical prescriptions have you seen? Do people think that it is not a proper treatment if it is not a drug or psychotherapy?
Well, the Prudence Trust have been very generous sponsors of some of our research on this. And actually, one of the things that we've seen very clearly is a very high appreciation from patient groups on this. I mean, crucially, this isn't typically offered instead of other medical treatment unless there isn't a good medical offering available. So I think that there has been some really good work amongst healthcare professionals and amongst the broader societies that promote social prescribing to let people know they're not being fobbed off if they're given this. Naturally, some people go to a GP hoping for a drug, so there can be a transition in explaining why there isn't a simple fix necessarily for them, but social prescribing could be beneficial. But actually, if I return to that example of young people on waiting lists for mental health services, one of the things that came back from our initial research on this was young people saying they were desperate for anything to do and that they felt like hobbies or leisure activities could be really beneficial for their mental health. So I think there is an appreciation that people know that they need this broader support.
Thank you, Daisy. And as you know from our kind of big RCT that we worked on together, it was remarkable to see that people who were very deprived and actually quite unwell, many of them, were extremely keen to take part, as were their doctors who were kind of the official referrers. So I was very impressed by that actually myself. So yeah, no, it's really very interesting. The next question on the list is, can leisure activities help people with chronic fatigue, stroke long COVID, when the nature of these illnesses make it difficult to engage in activities?
We've actually been collaborating on several trials on long COVID, and this has been a really interesting one because we've been looking at interventions that support breath, so singing-based interventions. Interestingly, these have been delivered often online as some of these trials instead of in person, which has reduced the issues around people getting fatigued by traveling to sites, but still given them the sense of that community and that opportunity to do breathing exercises, singing exercises, and have tools that they can continue to use in their spare time. So I'd say that it can work. Those trials have had some good results, but I think this is around the importance of designing interventions for particular patient groups. If you were to tell those same people to travel across London to an activity, that might not be actually in their interests. And that's why the sort of high precision social prescribing and the role of the link workers is so critical in considering the whole picture of a person and what they need.
Yeah, thank you. Thank you very much. When I don't read out a name, it means that it comes up as anonymous on the Slido, so I'm sorry. The next question is, could you argue that Maslow's hierarchy of needs plays a part in the health inequalities seen in engaging with social activities, for example, poverty and race?
I'm not particularly a fan of the hierarchy of needs because actually the evidence suggests that people can experience things like self-actualization and high levels of well-being, even if they have, so-called deficits in things like basic needs. But certainly literature on the leisure and community-based activities demonstrates that they do support across the sort of so-called higher up needs. I think an important thing there is that we are aware of what social prescribing can and can't address. Social prescribing might help a family to access more benefits if they're referred to benefit support that could address things like food insecurity, for example. But that doesn't stop us from needing to address food insecurity or poverty at structural levels, even outside of the individual pathway of social prescribing.
Great, thank you. Now, the next question is a very interesting one. Is how does social prescribing affect politics? I don't know whether you can provide an answer to that. It can, I guess, it can be quite a big. It's quite a big question.
does it affect politics is a big one. I mean, I guess it's interesting seeing the political engagements with social prescribing in different countries. I mean, it was brought in the UK initially under Conservative governments, which might not have been what people would hypothesize would have happened. But actually, we're seeing it's getting quite broad. It's getting quite broad acceptance cross-party in lots of different countries. There was one interesting thing we saw from our US research, though, which is we looked at the voting intentions of people and looked at whether that meant they were more or less likely to say they would follow a doctor's referral if they were referred to an arts activity. And Democrats were more likely to say they would follow the referral compared to Republicans. So I think there are still some sort of political entrenchments here, which could be around whether people want to take instruction from certain authority figures or not within society, or also whether they do value things like leisure in the same way. So I do think politics does come into play with this.
Yeah, that's very interesting. I did wonder whether I can't query the exact background and intention of the question. I would have interpreted as well as whether health policy, or our conception of the politics of mental health and health in general, I guess, are affected by social prescribing. Do we change our views about what they are in society, what illness is in society, and things like that? So that's how I had interpreted the question.
Interesting.
I may be wrong.
No, that's a really interesting interpretation of it, probably much more right than mine. I think that social prescribing is challenging us to think more broadly about what it is that people want fixes to. There's a sort of simplistic thing of, does a doctor say to a patient, what's the matter? Or do they say, what matters to you? And social prescribing can be a really effective way of saying what actually matters to this patient. Are they happy living with some of the health symptoms that they have? But there are broader factors that social prescribing can help with. And I think it encourages us to think about patients as people. And one of the things I really like about the model is it's really individually tailored. You not only necessarily have one session with a link worker, but multiple sessions. And this really allows link workers to get to grips with people's goals, their aspirations, what they define as health themselves. So in that sense, I can see it really does challenge our definition of health, not just being the absence of an illness, but actually really being a much broader social, physical, mental well-being.
Thank you. That's very helpful. Can I ask you another question that has been on my mind? What do you consider possible kind of adverse effects, side effects that could occur? Again, we didn't find much evidence for something like that in the RCT that I had that we're both involved in. But more broadly, is this something that I'm sure it's something that's on your radar and people have been tracking, and have you any thoughts on this?
We did have some really interesting research we carried out with voluntary and community sector organisations a few years ago, and they were saying that they often had a concern that staff within, let's say, arts organisations were being expected to act as kind of pseudo health professionals, managing people with complex needs who were being referred over, but staff weren't necessarily being given the training or the support or the funding to actually be able to know how to deal with this. So I think that we do need to have a stronger infrastructure on that training and support for third sector organisations. And I think there's also a big risk if people are referred over to these activities and then activities get cut because of funding, that can leave people even more in the lurch. They might have started to use community activities as an important part of their day-to-day support. So I think this is more sustained funding for the community activities is really essential. So we're offering people sort of longer term programs they can engage with rather than dropping them after short periods.
Right. And I think this is the final question. Debs Teal is the person asking the question. They say, arts gave me more skills for life than any medication or counseling. How can we measure quality of life? Because that matters to me more than the money saving through the NHS.
This is one of the reasons I think we don't want overly broad trials, because sometimes the argument comes down to like, what's the common outcome that we could look at across all social prescribing trials? But that obliterates the point that the outcomes could be really different in these different population groups. So that's why I'm quite a strong advocate for studies that will look at particular groups, look at like what were their symptoms in the first place, what were their goals, what are the particular outcomes that were affected. We're lucky we have really nice research tools, so lots of different validated measures of things like quality of life, alongside qualitative research that can get at things that might be harder to quantitatively put a value on. But I think we need trials that combine those approaches with particular population groups if we're actually going to have the nuance to pick up on these highly complex effects that social prescribing can have on people.
Well, we've come to the end, unfortunately. Time flew. Thank you so much. Thank you to Professor Fancourt and to all people who helped organize this lunch hour lecture. Thank you very much to the audience and to the questions that they asked. I'm sorry we couldn't ask all of them of Professor Fancourt. Please remember that we have another lunch hour lecture on the 6th of March. Is that right? On the artificial intelligence revolution is here, why we all need AI literacy in higher education. And thanking Daisy Fancourt once again, I want to close this event. Thank you so much.